Good afternoon, and thank you very much to the organizers for the opportunity to present in this nice meeting. So these are my disclosures. I have no personal conflict, but I'm going to discuss some off-label uses. One of them is the use of gadolinium contrast agents for MRI, which is not approved for cardiovascular imaging, and also all the modalities that I'm going to talk about are actually not approved for plaque characterization, which is what we're going to discuss. So I will go over these five steps, or these five sections in my talk. The first one is the definition of what a vulnerable plaque is. And we all know that. We all know there is a high-risk plaque, a plaque that has a high chance of rupture and of having a superimposed thrombus that can create an acute syndrome. Now, from the standpoint of imaging, these are the things that we're going to be looking at. So this is an example of all the features of a vulnerable plaque or a high-risk plaque. So from an anatomic point of view, it's a large plaque that grows both inside the lumen, creating a reduction in the lumen area, and also is growing outside, is growing outwards. So this is called positive remodeling. It's one of the features that we're going to be looking at. So we're going to be looking for large plaques that cause some stenosis and that have positive remodeling. This narrowing is going to create some alterations in the flow, which you can measure in the cath lab with the FFR, and also is going to create some changes in the plaque stress, in the shear stress. And that is going to also favor the rupture of the plaque when this stress increases in this area. Now, from a composition of the plaque point of view, these plaques typically have a large necrotic core, a large lipid core. So we're going to be trying to look for that also with imaging. They have a lot of inflammation, so these are macrophages, and these macrophages come into the plaque because they want to remove the cholesterol. The cholesterol is a foreign body inside of the artery, and the body is trying to respond to that and trying to eliminate it. But these macrophages, when the cholesterol is very high, they're not going to be able to do it. But they release proteases and enzymes that are going to actually damage the tissue, and they're going to be able, they're going to contribute to the rupture of this structure here. This is the fibrous cap that separates the core from the lumen. When these ruptures, the two get together, and the necrotic core stimulates the formation of a thrombus. So that's one of the reasons why the thrombi form. So if you have a lot of inflammation, there is more risk of this rupture of the fibrous cap. Then another feature that we're going to have is neovessels. So there are small vessels that come from the outside of the vessel itself, trying to reach this area because there is little oxygen in this area. So the body responds developing new vessels. These new vessels are not normal, and they actually leak red blood cells. So there's actually bleeding inside of the plaque because of these neovessels. So we'll be looking for that too. And finally, microcalcifications or spotty calcifications, they are also components of high-risk plaque. We don't know exactly why this is, probably because there is an interaction between a hard material and a soft material, and that creates some mechanical stress in the plaque that can actually lead to rupture. So these are all the things that we're going to be looking at. Now, how are we going to be doing this? So the first modality that we have is ultrasound. So this is what we're looking for with the ultrasound. This is just a 2D image of the carotid arteries. This is the lumen, and this is a plaque within the carotid artery. So where can we use the ultrasound? We can do it in the carotid arteries, we can do it in the aorta, and we can do it in the iliofemoral arteries. And if you look at this study, this is being performed in Spain. It's called the PESA study. So actually, the more prevalent area for plaques is the iliofemoral arteries. However, most of the data comes from the carotid arteries. And what about the plaque characterization, which is the topic of the talk? So basically, we're looking for the appearance of the plaque as either echolucent, which is this kind of dark plaque here, or either echo-rich, which is much more bright. So these two plaques in histology correspond to lipid-rich plaques, sometimes with intraplaque hemorrhage, so with the bleeding inside of the plaque, and these ones correspond to stable plaques, which are fibrous-rich and very calcified. So again, the calcium that is associated with a high-risk plaque is spotty, small calcifications, but once the plaques stabilize, they can have big calcifications, but those are different though. So we know that these echolucent plaques, the ones that have a lot of lipids, are actually associated with cerebrovascular events. Again, these are studies in the carotid arteries, so you would imagine that the event is going to be in the brain. And if you look at this meta-analysis here, you can see that the pooled risk ratio is actually 2.7, meaning that if you have one of these plaques, you have 2.7 more chances of having an event than if you don't have one. But also you can see that the risk of coronary events is increased. So this is the survival without coronary events of patients that don't have an occlusant plaque, and this is the ones that do have an occlusant plaque. So why would a plaque in the carotid be associated with coronary events? Simply because of the fact that once you have high-risk plaques in one territory, you can have them in any territory. So you're more likely to have them also in the coronary arteries or in the femoral arteries and so forth. And one more thing that we can do with ultrasound is try to see the neovessels, those small vessels that I told you about. So this is another example of a big plaque here, and then we give the contrast, the microbubbles, which are seen in the lumen here, and the small arrows point to some microbubbles that you can see inside of the plaque. So there is no data yet whether this actually is clinically meaningful, but again, some non-invasive ways of looking at this component of the plaque. All those images that I've shown you, they are 2D images, which is the most common type of ultrasound that we use. But now we're starting to use 3D ultrasound, so you can not only measure the area of the plaque in one slice, but you can actually put them all together and get the plaque volume. And there is some data already from actually Dr. Weber, who's going to be presenting later. And this is a study, this is the HRP study actually, comparing carotid plaque burden, which is the volume of the plaque, with the calcium score. And the calcium score is the most powerful marker of risk that we have in imaging today. So you can see that the more plaque you have, the more events, both with the carotid plaque and the calcium score. But if you look at the magnitude of those curves, they look pretty similar. So here, it doesn't seem that calcium score is necessarily better. It seems that maybe the plaque volume is as good as the calcium score. So this is only one study, and there will have to be more evidence, but it's an interesting way of looking at cardiovascular risk also. Now, if we go into MRI, so with MRI, we use a technique which is called black blood imaging. I mean, there are many different types of MRI acquisitions that we can do, where they are called MRI sequences. The most common is the black blood, where the blood obviously is dark, and we can see the vessel wall right here in the different vessels in the body. So we can get the cross-sections of the vessel, we can calculate the areas and the volume, so we can look at some of those features that I told you about, large plaques with positive remodeling and so forth. And then we can do characterization. And if you look at this is the same plaque image in 3 different ways. And here you can see, for example, there's a little bit of a bright area, this one is much more homogeneous, and this one here has a dark area. So this dark area actually is a lipid core. So by using what is called multi-contrast MRI, which is not because it uses contrast, but just because we look at it in different ways, you can characterize the composition of the plaque. We can get an idea of the fibrous cap, and this is an example of 2 plaques. This is one with a thick cap, and this is one with a thin cap. Now, the thickness of the fibrous cap, what is a thin fibrous cap? It's less than 65 micrometers, and the resolution of the MRI is not that good, so we cannot see it. But the thick caps, we actually can see them sometimes. So you see this dark line here, this is a thick cap. When you don't see it, this is consistent with a thin cap. So it performs reasonably well when it's compared with histology. And then one more thing that we can look at with MRI is neovascularization also giving contrast. So this is a cross-section of the vessel. This is the plaque here, this area, and it has 2 dark spots that correspond to calcification. When we give the contrast and we wait a few seconds, you can see that this part of the plaque is now brighter because the contrast is entering from the neovessels into the plaque. So again, we can try to analyze that, quantify how much perfusion there is, and then from there try to decide or try to get an idea how many neovessels, like it has been validated histologically, the plaque has. And another important one is intraplaque bleeding, as I mentioned before. This is done with a different type of sequence, and when there is fresh blood in the wall of the vessel, we can see it as a bright area, and again, validated with histology. So this one actually has been linked with cerebrovascular events in a number of studies. And you can see, again, this is the pool hazard ratio, which is 5.7, meaning that when you find this in a carotid plaque, there's 5.7 more chances of having a cerebrovascular event than if this finding is not there. And not only that, also the MRI has shown in one study that, again, the presence of abnormalities typically in the carotid arteries, where this is done, is associated also with cardiovascular events. Same thing as we saw with the ultrasound. So if you have a high-risk plaque in one territory, you're most likely also to have it in other territories. And in this particular case, it was the remodeling, when there is positive remodeling and when there was a lipid core. The combination of those two was predictor of cardiovascular events. Now, the main limitations of ultrasound and of MRI for you is that they are not done in the coronary arteries, non-invasively. And there's some data with MRI, I'm presenting it here. So this is a technique similar to the one that we use to look at plaque bleeding in the carotid, but it's done in the coronary arteries. And this is the corresponding CT image where you can see a plaque here. Now, the bright in the CTA is calcification, but in MRI, the calcium looks dark. So this bright thing is something else. Because of the evidence that we have from the carotids, we believe this is probably intraplaque hemorrhage also, but this is not completely validated yet. But in any case, in this study that was published last year, so these are patients followed for about 5 years, and basically what they were is divided into patients that had coronary artery disease or not, significant coronary artery disease, and patients that had this finding, yes or no. So if you can see that the survival of those that didn't have coronary disease or this was very good, the ones that had both significant coronary artery disease and potential intraplaque hemorrhage, they did the worst. But for me, the most interesting part is this area here, which is the patients that had only coronary artery disease or only this thing. So if you have only this thing without significant coronary artery stenosis, the outcome was the same as having coronary artery stenosis, even though angiographically they would not be considered high risk. If we go on to the next modality, positron emission tomography. So basically what we do here is we give a radioisotope, and this isotope is going to be taken by certain cells. So in the case of atherosclerosis, the most studied has been FDG. This is an analog of glucose. So the cells that are very active metabolically, they take up a lot of glucose, and they're going to take up this molecule also. When you have a lot of inflammation in a plaque, the macrophages are going to be taking that glucose. So it's going to have a bright spot in the PET. Typically, PET is done with CT. So this is the cross-section of the neck. This here is the carotid artery, which you cannot see because there's no contrast. And here is the inflammation that we can see in the PET with the FDG, and this is the fused image. And you can see that the other carotid artery has nothing. So there's no inflammation here, but there's inflammation there. And again, when you look at the correlations with histology, you can see there's a very nice correlation between how many macrophages there are here with this CD68 staining and how much FDG uptake there is in the plaque. So this has also been linked to cerebrovascular events, although the evidence is a little soft. So there's probably an association between having uptake in carotid arteries and having more risk of stroke, but we don't know that for sure yet. But there's one study that has looked at the association between uptake of PET in the carotid arteries and, again, cardiovascular events, not only in the brain, but everywhere. So in this particular study, the combination of both increased uptake in the carotid arteries and an increased thickness of the vessel wall was associated with the highest risk of events. So again, having a large volume of plaque represented here for the intima media thickness and also having inflammation, the combination of those two is a bad combination. Now, there's the possibility of doing PET and MRI together. So there are hybrid machines that can acquire both modalities. So instead of doing PET CT, it would be a PET MRI. This is a study that we're doing in Spain. And again, it's the PESA study. And we're imaging the carotid arteries, the abdominal aorta, and the iliofemoral arteries with both techniques. So hopefully we can get composition from one of the techniques, which is the MRI, whether it's a lipid-rich core, a fibrous cap, and so forth, and then whether it's inflamed that we can get from the PET. We don't know if that's going to provide prognostic information because the study is ongoing, but certainly it's going to be a very interesting to see what the findings are. PET typically is not done in the coronary arteries. It's difficult to do, but there are some studies showing the feasibility with FDG and then also with this other isotope, which is called sodium fluoride. And this isotope binds to calcium, actually. But it's interesting because it doesn't bind to all sorts of calcium. It seems to bind to areas where the calcium is forming. So if you have a stable calcification, if you will, you're not going to see uptake of the isotope, but if the calcium is forming, then you are going to see it. And in this particular study, which is one of the first one published in the Lancet, so what you can see is when you compare, these are patients that had a heart attack, and the uptakes were comparing the culprit plaque and in other plaques, and in other plaques that were not the culprit. So you can see that the FDG, the inflammation, was similar, but the amount of uptake of the sodium fluoride was increased. So again, very preliminary data, but perhaps those microcalcifications that we're talking about, we can detect them with this isotope better because, and sometimes they are too small to see visually. So maybe we can detect them better because that's when the calcium is forming, not when the calcium has already stabilized. And then for the coronary arteries, by far the most robust technique that we have today is computed tomography. So we can quantify plaque size and get an idea of the plaque volume. This is an example of the LAD. Here in dark, you can see a non-calcified plaque with the arrows there. So we can do a cross-section here, and we can trace the area of the lumen and the area of the outer border, similar to what you do with the IVUS. It correlates well. It's not definitely as good as the IVUS is, but there's a reasonably good correlation between the two in terms of quantifying plaque size. Another thing that we can try to do is spot calcifications. As we mentioned before, another of the features of the high-risk plaques, so like this one here in the cross-section. But again, as I said, many of the microcalcifications are too small for us to see. So we see the bigger ones, but we don't see the smaller ones. We can look at positive remodeling. So again, this is a coronary artery. This is a big non-calcified plaque, and you can see that the plaque is not only growing inwards, it's also growing outwards, so we can quantify how much remodeling there is. Another very important feature is low attenuation. So if you look at this plaque here in this cross-section, you can see there's a dark area here. We measure the attenuation, which is, in this case, 20.5 Hounsfield units. So when it's less than 30, this is a very specific sign of a lipid core, because the lipids have lower attenuation, so they look darker than other tissues. So there's a very interesting study led by Dr. Narula here, and this is now there are 2 publications with a follow-up to 4 years. What they basically looked is the patients had CTs, they identified plaques, and they considered them high risk if they had either positive remodeling or low attenuation, less than 30 Hounsfield units, as I said. So they followed these patients, and some of them developed events, and they could see in the cath which plaque had created the event. So actually, these particular plaques, when they had these features, were associated with many more events than the plaques that did not have those. So it suggests that in finding these features in the CT angio, you can predict who is at higher risk, whereas stenotic lesions that don't have those features may not be as risky as we think. And finally, I will conclude talking about FFR. So there is a new approach which is trying to measure FFR non-invasively with CT. And the way it works is the following. So we acquire the images. We create a 3D reconstruction of the patient's coronary arteries. So it's a patient-specific model. And then computational fluid dynamics is applied. This goes into a computer. The computer, don't ask me what it does, processes the images for a number of hours, and then spits out a number. It spits out a number of the FFR would be. So it's applying, again, principles of physics to determine what the blood would do at rest and what the blood would do in terms of pressure, flow, and so forth if you gave a vasodilator, like, for example, adenosine. But this is done without giving any adenosine. Now, the first time I heard about this, I was thinking, this cannot work, right? So it actually does. There's a number of studies now, and this is the largest. So this is comparing CT alone or CT plus FFR with the FFR in the cath lab. And you can see that the accuracy with the ROC curve is increased when you use this method. So even though this is tough to understand because it's complicated equations that are applied, so it seems that it's a valid approach to try to predict who's going to have an FFR positive lesion. And finally, just to conclude, the same fluid mechanics principles can be applied to try to calculate shear stress, which is another component of the high-risk plaque, which I mentioned. So typically, areas of low shear stress favor the development of plaque, but areas of high shear stress favor the rupture of the plaque. And with this, I conclude, and thank you so much for your attention.